So hi everybody, this is the second installment of the Let's Get Prepared series, and this one is on trauma. Let's get started. So I just wanted to point out some statistics that we have from our OR, and in 2019 we did over 8,000 cases in the OR, and 79 of those were classified as stat cases. So what does stat actually mean in ROR? So I want to point your attention to the E codes that you've seen on the booking slip and just do a quick little review of what the E codes were. Um, you can see that E0 is now down to E4, which is within 48 hours. So why is it important to pay attention to the E codes? So the E codes tell you how quickly the patient will be coming to the OR. There are very, very few times when you will get an E0 booking. A possible example could be if the surgeon is on the call to ICU from the field and they let the ICU lets the OR know that there'll be a trauma call, and there will be very little stopping in Emerge to do any assessments or any stabilization. It'll be straight to the OR. So in those cases, it's vital to call your call people in and be prepared. So the question is, there's so many types of traumas. How will I know what to do? And I want to just have you think about your ABCs. So in the case of traumas, you think about what's going to kill the patient first. Most likely, they have the A and the B secured either in the field or in Emerge, so that leaves us dealing with the C. If we're thinking about that in terms of CARTs, laparotomy or open heart, and addressing the other issues like orthofixation would be after. So you're going to do the A, B, C of the laparotomy and open heart, and then you're going to fix the sort of further down the alphabet orthofixation. So thinking about the ABCs in another way, you can think of them in categories. Is there an airway thing, like a burn injury, transection of the airway? That would be the A. Is it a breathing thing, like a crush injury or hemothorax related to a high velocity injury? That'd be a B. Or is it a circulation thing, like a major bleed in a large central artery or in the head? That's a C. Any of these things could come stat to the OR, and any of these things could fit in with one of the 3 stat case cards that we have in the OR. So then the question inevitably is, so what do I pick? So depending on the mechanism of injury that we talked about on the previous slide, you may need more than one of the case cards that I mentioned. So thinking about what you have for stat case cards, a heart, a belly, a head, and an airway. Thinking about this then in the context of the ABCs, it becomes clear what we need to bring in to be prepared. So the trauma pager call, the trauma pager callback can give you a clue. Say you call an Emerge and get report that there's a PED struck with an ETA of 15 minutes. What case card could fit this scenario? If you said the laparotomy, the cranie, and the heart, you'd be correct. What about a seatbelt injury? I'd probably pick the laparotomy. How about an ejection? You decide. So if you said maybe the cranie, the laparotomy, or the open heart, you probably could sort of navigate that case. So at the first page from Emerge, there's not a lot of information to go off of, but you can complete the first step of making sure that your cart options are available and complete. The next step would be to ensure you have let the rest of the team know that there's a case coming into the room. So who do I need? Often, especially after hours trauma, you'll need an extra set of hands to check blood, open case instruments, help with positioning, difficult airways, all those things. Please don't hesitate to call on the on-call nurses, as large rapid traumas can quickly overwhelm the staff in the room. It's far better to call your call nurse in and have them leave early than to be caught out with unforeseen needs and need those hands than call them late. So inevitably, in a trauma situation, the conversation around blood comes up. So what do you need to do? So the massive transfusion protocol is located in the PD crisis book in the purple section on EPUBs under massive transfusion protocol and on the anesthesia clipboard. You'll need to call transfusion medicine TML at 7388 to start the massive transfusion protocol. Transfusion medicine TML is also called blood bank. TML, when you start the massive transfusion protocol, will tube you via the pneumatic tube no more than 2 units of blood. After that, the OR team needs to designate a porter or SSA to be the runner to pick up the blood. Please give them a blood release tag with the patient information on it. A sticker is okay, so that TML knows who they're releasing the blood for. More resources on both the Learning Hub as well as on EPUBs under transfusion medicine or blood will give you more information. The tubes needed for a blood situation vary. However, cross-match group and screen require a purple top tube, which is also an EDTA tube, and a handwritten label located in the blood caddy. So the requisitions are next. So these are all the required requisitions for a blood administration depending on what stage you are at. The small half sheet is the blood release tag. This will be needed in a situation of massive transfusion protocol. Your runner will bring this as identification of the patient you're transfusing in the OR. Also, if there was blood ordered for a patient, this will be needed by the blood bank to release the blood to the unit. In slated cases where the blood has been sent to the fridge, this sheet is not needed. Check the learning modules on the Learning Hub and EPUBs for specifics on how to fill out the group and screen, paying close attention to the piece about signing the requisition and the tube. This will save you lots of time in a trauma situation and avoid rejected samples. Please note that in a true emergency, there may not be time for the physician to get blood consent signed by the parents. There's a box to check on the release tag to circumvent this. So still more paperwork associated with blood. So these are all the forms that are needed when actually checking the blood for patient use. Now we talked a little bit about the far right rec, which is your consent, but all the rest of them are needed in your blood situation. So included in the photo is a transfusion record, the admission summary record of the unit of blood with the tags attached, and the blood consent. When pulling the blood from the fridge, ensure you have some form of identification with the patient information on it, and note the time, as blood is only good for 30 minutes in a non-temperature controlled box. There's a Learning Hub module on how to remove the blood from the satellite fridge if you're interested. So communication is vital in a trauma, as we all know. When you answer the page to emerge, anticipate that the trauma is going to come to you, regardless of what it is. Assess who you have in the department and notify everyone that you see. Talk to anesthesia and the AAs to let them know the situation. And remember, they don't get the trauma call-out pages, so if they're there, let them know because they don't necessarily know already. This doesn't mean that they need to be on the trauma call-out, but if they're in the department, start taking roll of who's there. Designate someone to locate and confirm that the appropriate case carts are available, and determine if there are options available for room use. Are you going to use 3? Are you going to use floor 4? As the responding OR charge nurse in Emerge, take a look at who's there. Do you recognize anybody? Is that the general surgery resident over there? Or how about the anesthesia fellow around the corner? Is that neurosurgery you see? What are people actually talking about in the trauma bay? Is the plan to go to the scanner first? These are going to give you clues as to what they could be expecting and can guide the urgency of the setup in the ORs. Think about your role definition while you're down there. So meanwhile, upstairs in the OR, what are you doing? So in addition to the stat case cards, start thinking about what else the patient may need. Is everyone on the same page in what room to use? Is there enough section capacity? Do you need another tree in the room? How about a bear hugger and a Megadyne? What about enough linen and suction liners? Are the lines ready? Are the case carts ready to go? Are they outside your door? There are many things to think about when getting a room ready for a trauma case, but by doing so systematically, maybe start with the anesthesia stuff and move outward, it'll help you. Remember your defined role and stick to it. When the patient comes to the OR, it'll no doubt be loud and there will be many people there. While this will be necessary at the beginning, when possible, ask people to head out of the room if they are not involved in direct patient care. This will help not only keep the noise in the room down, but also the microbial count in the room lower. We still need to maintain vigilance around protecting the sterile field and patients from unnecessary harm in the form of SSIs. So unfortunately, sometimes the outcome is not what we want. We are fortunate to work in a highly skilled team environment with very resilient populations. However, sometimes our patients are too injured to survive. In this instance, we need to complete care of that patient in a particular way. ORNAC, in alignment with the provincial government, denotes death in the OR as a coroner's case. This means that after the declaration of death, the surgeon, most likely, must contact the coroner's office before anything else happens. This includes removing the drapes, instruments, or equipment from the operating room. The coroner will then direct the sequence of care. She or he will come to investigate right away or will do so in the morgue. If you are given the go-ahead to send the patient to the morgue, follow the documents on EPOPs on caring for the deceased in the operating room. The ICU is a good resource if you're feeling overwhelmed and can give you guidance on the care of the body. If the case is a police case, remember that maintaining the chain of evidence is important for the legal proceedings, and handling the body is done so that that chain of evidence remains intact. Also know that in the case where the passing was unexpected and traumatic, a parent may wish to see the child. In this case, a conversation with the rest of the team can help coordinate and navigate this difficult situation in a family-centered way. I'd like to thank you for listening to the second in the series of Let's Get Prepared, and have a good day, everybody.